Hello everyone, myself Dr. Namrata Vithalani. In this video, I am going to share an interesting case which presented to us. So this is a case of young female patient who presented to us with history of dyspnea at rest and hemoptysis. So and she also had one episode of fever on presentation, which was associated with the cough. So initially from the symptoms, she was having history of fever, cough, dyspnea, and hemoptysis. We considered clinically to be some form of lower respiratory tract infection, and looking at her build and stature, she was a bit malnourished. So we had possibilities of either community acquired pneumonia or associated with the pulmonary coughs. So we ordered an initial investigation, complete blood count which was suggestive of leukocytosis, raised CRP was there, and we ordered the chest x-ray which was suggestive of opacities involving the right side of upper, middle and lower zone, mainly more in the middle and lower zone. Then based on these findings, we ordered the HRCT chest for this patient, so which was suggestive of a large consolidation involving the right side of the hemithorax, mainly middle and lower zone, a bit in the upper zone also, and also presence of bilateral pleural effusion. So with this much of the history and radiological findings and the basic laboratory findings, we had in mind that some form of infective pathology is there. But why this young female would develop such a large consolidation? So on detailed clinical examination, we saw that there was also presence of discrete hyperpigmented skin lesions all over the body. She also had hair loss. She also had proteinuria. In the urine routine, there was presence of the 4 plus proteinuria was there. And so for the further evaluation, we sent the sputum routine microscopy, gram stain and AFB, which was negative. Then we evaluated the pleural fluid for the further analysis, which was suggestive of the exudative pleural effusion. We sent a pair of 2 bottles of blood culture, which were also sterile. But considering this much large consolidation, we started her on empirical treatment for community acquired pneumonia, and we evaluated the pleural fluid also, which was exudative. On echocardiographic evaluation, we found that she was having generalized LV hypokinesia, moderate LV dysfunction, along with moderate LV dysfunction. LVEF around 30 to 35% was there, and we also ordered for the cardiac enzymes troponin, which was positive, and pro-BNP, which was more than 35,000. So there was presence of moderate LV dysfunction, volume overload, bilateral pleural effusion, and IVC was also less than 50% collapsible with the respiration. So there were basically there were features of volume overload and moderate LV dysfunction were there, along with the bilateral pleural effusion, and she had proteinuria. So with this much of the clinical presentation, we had in mind that okay, patient is having community acquired pneumonia along with maybe some form of connective tissue disorder underlying because of this pattern of multisystemic involvement. Say patient was having proteinuria with pleural effusion, with LV dysfunction was there, with this much of the cutaneous manifestations. So I ordered the anti-nuclear antibody ANA by immunofluorescence, which was strongly positive 3+, and Then we also ordered for the complement levels, which were also low, and we had evaluated the full ANA profile, so which was strongly positive for anti-dsDNA antibody, and anti-Smith antibody. So that we arrived to the diagnosis in this patient according to the criteria that in the clinical criteria, patient had fever, features of serositis, bilateral pleural effusion. She had oral this cutaneous manifestations, hyperpigmented rash was there. She was also having proteinuria with low complement level, anti-dsDNA and anti-Smith antibody was positive along with the low complement level, so which satisfies the diagnostic criteria for the SLE. So ultimately we arrived to the conclusion that patient is having underlying connective tissue disorder, now presented with the community acquired pneumonia and volume overload, myocarditis. Thank you.